Hey, this is Rebecca. Today we're going to be talking about chapter 38 for MedSurg 2, endocrine system function and data collection. So this is kind of the intro to the endocrine system. I'm going to go ahead and share my screen. You can follow along with the PowerPoint if you like. All right, there we go. So some of our outcomes for this little mini lecture today, which by the way, I think this should be 20 minutes or so. It's not going to be a super long one. We want to identify the glands, talk about the function of the hormones, which those glands secrete, talk about aging on the endocrine system, data collection, our assessment, right? And then assist in planning some of the nursing care for patients that have that are having testing for an endocrine disorder. Concepts are going to be cellular regulation and fluid and electrolyte balance. So just to review some of the anatomy, because I know history or anatomy and physiology was a while back for some of you guys. Up here, right underneath your brain, you have your hypothalamus and your pituitary gland. Right around your neck, you've got thyroid, parathyroid. Your thymus is right here in the middle of your chest. Your adrenal glands are right, kind of sit like little hats on top of your kidneys. And then your pancreas is kind of right in the middle. And then in females, we have ovaries. And then in males, we'll have testes. So let's start up top, yeah? So pituitary, excuse me. So the pituitary is tiny. It's about the size of a pea. It sits right underneath the hypothalamus. Um, and then in the pardon me, the pituitary, actually beside, even though it's small, there's the anterior, kind of in front, and posterior pituitary. Um, in the hypothalamus, kind of right, you can see it right up here, or here's the better picture of it. It has a lot of synthesizing or releasing hormones. They stimulate the pituitary to secrete some hormones. Other hormones are inhibiting hormones. So let's get into a little more about these. So the anterior pituitary, so you can see how here this is highlighted, this is the anterior side. So it produces thyroid stimulating hormone, and which is kind of self-explanatory. When that hormone is released, it stimulates the thyroid to secrete thyroid hormone. Okay. The prolactin, it stimulates mammary glands in females. In males, it might make the testes more sensitive to LH, which is lutein hormone. The adrenocorticotropic hormone, or ACTH, that stimulates the adrenal cortex to secrete corticosteroids. So these are more like the secretion hormones. Here's growth hormone. It acts all over the entire body, where it increase protein synthesis, lipid and carbohydrate metabolism. It's basically growth, everything you need to grow and get larger. So especially as children and are, from birth, through puberty, that's definitely going to be a lot. Clean up that later. So LH, we talked about that when we were talking about prolactin. That stimulates ovulation and estrogen for women. And then in men, it has secretion of testosterone in men. Then there are follicle stimulating hormones. That one helps stimulate production of eggs in females and sperm of the testes in men. So then if we move to the posterior pituitary, it stimulates oxytocin, and that really deals a lot with childbirth. So it stimulates the contraction of the uterus during childbirth, and also stimulates the mammary tissue to produce milk during lactation. It also produces ADH, or anti-diuretic hormone, which I always think I like to break down that one because it is self-explanatory, but sometimes you kind of have to wrap your brain around it. So let's break down the word anti-diuretic hormone. So anti-diuretic. So what is diuretic, right? You think, okay, if I give my patient diuretics, we're going to diurese. We're going to pull fluid off, right? So Antidiuretic means it's against it, right? It is going to keep more fluid. So it actually stimulates the kidneys to reduce the urine volume, how much we're getting rid of or excreting. And so it helps to increase your fluid volume. It also helps to increase, by increasing fluid volume, that also increases things like your blood pressure. Um, ADH sometimes is also called vasopressin. If you work or have been in a critical care unit, sometimes you'll see vasopressin given as a medication to patients to help increase their blood pressure. All right, so moving on to the thyroid gland. Excuse me. So you can see here in this picture how the thyroid kind of wraps around your esophagus and your throat. It's just below the trachea, and it kind of wraps around the anterior and then like the lateral portions on the side. It produces, so once it's been triggered, right, by the pituitary, it is then triggered to release T3 and T4. Calcitonin is also secreted by these like parafollicular cells. Interesting thing about the thyroid is that even though the thyroid secretes these glands, it can also store them up. And that's going to be more impactful when we do our next lecture. We're going to talk about how that impacts people with thyroid disease. So just keep that in mind. Thyroids can actually store up some of that hormone, the thyroid hormone. All right, then the parathyroid gland. So you see these little purple dots? Those are the parathyroid glands. This is the thyroid gland. We're kind of looking at it from the back, looking forward. These usually most people have four, and they kind of sit around kind of the lateral area. It can be different from person to person. But they produce PTH, parathyroid hormone. It inhibits stimulation of new bone formation and the breakdown of old bone. So it has calcium, it increases the calcium in the blood, essentially. It also encourages the kidneys to reabsorb calcium, right? Sending that message, hey, I need more calcium here. And it blocks the excretion in the urine. It also helps to promote the excretion of phosphate, which we talked about last week. You know, a lot of our renal patients have issues with building up phosphate in their system. Vitamin D, it's activated by the kidneys. This allows intestines to absorb the calcium that we need from food, right? Can't do much with your calcium if you don't have vitamin D. All right, so now let's talk a little bit about adrenal. So here is a picture right up here of a kidney, and you can see the adrenal gland kind of sitting like a little hat on top of the kidney. It produces a lot of these chemicals, or the, what are they called? Catecholamines. Stimulators. So sorry, I had a moment of not finding that word. So these catecholamines work in a few different ways. When you're getting ready to exercise, or you're going to get ready go for a walk, or you start doing something, your adrenal glands secrete these catecholamines to start to get your heart rate up, get your blood pressure up, supporting your body system in physical activity. It can also boost your glucose level by glycogenolysis, excuse me, where it starts converting some of your fatty acids into glucose. It's broken down into 3 layers. We're not going to really talk a lot about that in this class. Moving down to the pancreas, my favorite of our endocrine organs. You can see this picture here. Here's the liver, the stomach, and the pancreas is just kind of sitting back behind here. So you can't really see it in this picture well, but it's kind of sitting back behind the stomach. So here you can see how the pancreas, it's attached into the intestines. You also have your bile duct here leading from your liver. It is interesting that that there are several cells that do different things on the pancreas. There's alpha cells, beta cells, delta cells. We'll go into those a little bit more, especially um, week 4 and 5, I believe, and we're really diving into diabetes. And this just is a little bit of just an overview of regulation of blood glucose level. So here's a picture of your stomach, right? You ate something with sugar in it. I've been eating good and plenty. That's what just fell all over the floor along with my lights. Goodness gracious. So let's say you ate some good and plenty with me. Maybe you're licorice fans. I don't know, maybe not. But you eat that glucose is absorbed by your stomach. It goes into your bloodstream. The higher glucose levels then stimulate the beta cells on your pancreas to secrete insulin. Insulin triggers a couple different things. One, it triggers the cells to allow more insulin to go into the cells. It also triggers the liver to start storing some of that. It stores it as glycogen. We'll talk about that a little later as well. So when your blood sugars start then to drop lower, it's been a while after you ate, you've been exercising, whatever it is, then the alpha cells are going to might stimulate the liver to release that glucagon back into the blood. The glucagon, well, actually, yeah, so the glucagon, once it's released, then it causes that glucose, it converts that glucagon into glucose and puts it into the bloodstream, keeping your blood sugar back up. So a little bit of just the regulation of the blood sugar by the kidney or the pancreas. We'll talk more about this in a few weeks too. A couple of just overview things with the effects of aging, right? So as we age, like we talked in gerontology last term, it really does affect all of our body systems, including the endocrine system. So as we age, our growth hormone is going to decrease. With that growth hormone decrease, remember we talked about not only making you bigger and taller, it helps to produce muscle mass and fat storage. That's why a lot of our patients are not going to have as much muscle mass. They're going to not be able to store as much fat. They're going to have less THS and thyroid hormone in general. So those really affect your metabolic rate, which means you're not going to have as much energy if you don't have as much of that. They're also not going to secrete as much insulin by the pancreas. Because of that, they're going to have decrease in their what's called glucose tolerance, meaning when they have glucose, like they're good and plenty, you eat it. After that, they might not produce as much insulin, and so they're going to have higher blood sugars. This isn't necessarily diabetes, but it is something that does affect older patients. We might be seeing slightly higher blood sugars. So when we're doing our data collection, or data collection is just also called assessment, what are we assessing, right? So neuromuscular, right? We talked a little bit about some of the electrolytes like calcium that are regulated by some of these different hormones, right? Remember we talked about calcium way back last term, how you can have different tremors and different side effects with those imbalances. So that's just an example of why you'd want to look at neuromuscular status. You really want to look at weight change. Remember we talked about renal system last week. One of the best indicators of fluid balance is just a daily weight. What is their weight doing? Now, also with some of these diseases, especially that regulate, we're going to talk about in my next lecture, we're going to talk about some of these disorders and diseases of the endocrine system. It can kind of increase or decrease your general metabolism. And so when I say weight change, it might be that somebody is just losing weight all of a sudden or gaining weight all of a sudden. So that's a good indicator that something might be going on. We want to look at excessive thirst or urination, heat or cold tolerance or intolerance, right? They just like, I can't handle the cold. It just affects me too much, or they just can't handle the heat. Mood and memory, as well as what is their family history? Are there any family history in their life of somebody that has an endocrine disorder? So we're going to take their vital signs, their weight, look at their skin, note any changes, tremor, like I talked about a little bit ago. What's their affect? Exophthalmosis. Are their eyes bugging out a little bit? Um, Sometimes fatty pads, like you see people who have not just the kind of the humpback, but kind of they can produce this kind of fat pad on like on the upper back of the neck, back area. Sometimes they call that a buffalo hump. You also think about thyroid size. It's one of the when we're assessing our patients, we're not able to palpate for the pancreas or feel for those pituitary glands, but the thyroid, by way of where it's at, there's not a whole lot surrounding it, and you can palpate for the thyroid, and if it's enlarged we would be able to feel that. So activity, cue recognition. We go to our patient, we check their blood sugar before breakfast. It's 362. What do we do? All right, so pause for a second, think through, what would I do if I was in clinical and this happened? Well, hopefully you'd consult with the registered nurse and see if they need to have some insulin. Then you plan follow-up and teaching. Oops. The normal glucose level should be between 70 and 100. So 362 is pretty high. Um, Once we get the immediate, like the right now blood sugar managed, then we want to kind of probably look at a few other things and to see what's going on. So talking about common laboratory tests, when we're talking about the endocrine system, thyroid test, if we're looking at thyroid dysfunction, we want to get a thyroid stimulating hormone. We also want to get T3 and T4. Those are the thyroid hormones. For the parathyroid, well, we would want to check the parathyroid hormone, but because of its effect on calcium and phosphorus excretion and reabsorption, we would want to get those electrolytes as well when we're looking at the parathyroid. Pituitary test, well, growth hormone, that's one of the big ones we talked about, and the antidiuretic hormone. We'd also want to get a urine-specific gravity because of how we excrete fluid related to the pituitary test. That might give us a good indication of what's going on. And we might check for adrenocorticotropic hormone, or ACTH. For the adrenal dysfunction, we would want to definitely check a cortisol. And then you might see somebody have a 24-hour urine collection for vinylamindelic acid, or VMA. And so, like we talked about the 24-hour urine collections for renal dysfunction, kidney dysfunction, you might see it for other endocrine dysfunction as well. So for pancreatic dysfunction tests, we would want to get a fasting glucose level. There's a glucose tolerance test, meaning, like we talked about, somebody eating their candy, eating their whatever, and then their blood sugar is going to go up a little bit, right? We expect that. But our pancreas should produce insulin that would bring that blood sugar back down. A lot of pregnant ladies have to have this test done later on in the pregnancy to just check for pregnancy-induced diabetes. And usually what you do is you have somebody fasting, they don't eat or drink, and then you give them, the clinic I went to, they gave me this thick syrup to drink and it was disgusting. Another friend of mine went to a clinic where they gave her gummy bears to eat, which I was like, man, I want to eat gummy bears instead of this nasty drink. But then you check their blood sugar 30 minutes, an hour, sometimes 2 hours later, and you see how their body's tolerating that, chunk of glucose that they just got. You also want to check a glycosated hemoglobin, also sometimes called a hemoglobin A1C. So let's go over a few review questions. 38-year-old female comes to the clinic. She says she feels depressed, gradually gaining weight, lethargy. What is lethargy? Like sometimes you say you feel lethargic, or like just you don't want to do anything. It's hard to get up. You have no energy. That's lethargy. And she has very dry and flaky skin. What laboratory test do we anticipate the patient needs for possible diagnosis? So think through some of these issues they're having and what hormones we've just talked about. And it would be, number 3. T3, T4, and TSH. We're thinking about thyroid hormone. Now there's a question. 24-year-old male patient comes to the ER with diagnosis possible Addison's disease. Okay, we haven't talked about Addison's disease yet. So let's use some of our test taking skills. All right. Which of these assessment findings require immediate follow-up? All right, so we're taking this, let's just say we're taking a test and we're looking at this and going, I don't even know what Addison's disease is. But there are clues in this question that will let us know how to choose the right answer. It says, which of the following require immediate follow-up? So it's a priority question. What is the highest priority? So there's hyperpigmentation of the skin. That's where the skin gets discolored or darker in color than normal. Blood pressure of 90 over 52. Statement of fatigue and weight loss. All right, immediate follow-up. Which of these do you think would require is more life-threatening or has more potential for patient harm? Well, the first one that stands out to me is this blood pressure, right? It's kind of a low normal. When I look at hyperpigmentation of the skin, if the skin's changed color a little bit, that's usually not an immediate issue. If somebody says they feel fatigued, again, yeah, that's a problem. It probably there's something going on, but I don't see that as being more important than a low blood pressure. And then weight loss, same thing, right? So even if we don't know what Addison's disease is, we can rule out these other answers because we know that a low blood pressure is going to be more concerning than some of these other issues. And let's check. Yep, number 2 is correct. Good job, guys. All right, number 3, a 42-year-old female patient comes to see the provider statements of weight gain and mood swings. She also states her face has developed a round appearance. Her blood pressure is 150 over 86. What other signs of Cushing syndrome should the nurse observe? So let's think through Cushing syndrome. What do we think might be going on? Oops, I'm sorry. I just accidentally went. So if you saw it, the answer 1, 2, and 5. We're going to talk more about Cushing syndrome and the disorder. But with that, we might see thin, fragile skin, elevated blood glucose, and that fat pad on the neck. A 75-year-old male comes to the ER. He states he is very thirsty and urinating all the time. What additional data would you expect with his new diagnosis of diabetes mellitus? And so we're going to talk a little bit more about this when we talk about diabetes, but any other ideas? Well, the answer is weight loss. Because in diabetes, people don't produce enough insulin. When you are initially first diagnosed with diabetes, your blood sugars are very high, but you don't have the insulin to let that glucose into the cells. And so the cells are burning up, or they're getting sugars or energy from other sources, like breaking down your fat and even muscle to use those. We'll talk more about that when we do cover diabetes. All right, I think this is the last question. Oh my goodness, how did I get all the way to the end? Okay, let's get back. 52-year-old females admitted with the following sign and symptom. Which of these require immediate follow-up? Okay, this is another one of those. Good Lord. Sorry. Okay, which requires immediate follow-up? Tremor, weight loss, pulse 116, or nervousness. And again, we're going to go through like that critical thinking. Which of these things could be or would like potentially life-threatening or more severe? So tremorous hands, body maybe, some weight loss, pulse is a bit elevated, or nervousness. I'm going to say, the pulse, because that's a higher pulse, and I need to see what else is going on with it. I don't know what the blood pressure is associated with it. There's a lot of other things I want to know, but of all of those, that's the one that's most concerning to me. So, and it's correct, number 3. All right, that is the end of our little kind of mini lecture into introduction to the endocrine system and dysfunction. I'm going to have another lecture following this about endocrine dysfunction. We're going to do diabetes and pancreas dysfunction later in weeks 4 and 5. All right, so thanks for watching. If you have questions, I'm available on Canvas. Bye.